Now let's move on to nephritic syndrome. The most important thing to know about nephritic syndrome is that it's an inflammatory process. For whatever reason, something is leading to inflammation within the kidney itself. Typical presenting symptoms include hematuria with RBC casts, as well as azotemia, oliguria, and hypertension. The hypertension is due to the inability to excrete salt. And we'll also see proteinuria, but less than 3.5 grams per day. Our first nephritic syndrome is acute post-streptococcal glomerulonephritis, also known as APSGN. It's an acute process, and it usually follows an infection, often strep throat in children, and it's most commonly seen in children. It typically presents 2 weeks after an infection. And which Lancefield group of Streptococcus causes it? It's group A strep. Patients with APSGN have symptoms including diffuse edema, cola-colored urine, hypertension, and these symptoms and the disease usually resolve spontaneously. One interesting fact is that treating strep throat with antibiotics cannot prevent this disease, unlike rheumatic heart disease, where treating with antibiotics can prevent the disease. APSGN is a type 3 hypersensitivity reaction, meaning there's a hypersensitivity going on between the patient's antibodies and the bacterial antigens. And this leads to increased anti-DNase B titers and decreased complement levels since the complement is being activated by the immune complexes. On light microscopy, APSGN shows enlarged and hypercellular glomeruli filled with neutrophils, because neutrophils are what respond to bacterial infections. This condition is caused by, remember, immune complex deposition, and this deposition happens along the glomerular basement membrane, which leads to a lumpy, bumpy appearance. And that lumpy, bumpy appearance on immunofluorescence is caused by the deposition of those immune complexes along the glomerular basement membrane. And on electron microscopy, we'll see subepithelial humps, and that will be a key word pointing to APSGN, lumpy, bumpy, and humps. And that's also due to the deposition of immune complexes. So, 2 keywords to take away for APSGN: lumpy, bumpy, and humps. Next is rapidly progressive glomerulonephritis, also known as RPGN. And it's sometimes called crescentic glomerulonephritis because crescents form around the glomeruli, as seen here. This black arrow is the glomerulus, and the red arrow is the crescent. Now, this is a very serious condition with a poor prognosis, where renal failure can develop in weeks or even days. The crescents are made out of fibrin and plasma proteins, as well as cells that leak out of the damaged glomerulus. Eventually, these crescents, made of fibrin, plasma proteins, monocytes, macrophages, and parietal cells, they will come to fill that Bowman's capsule and will get a crescent forming around the glomerulus. RPGN can be caused by a number of diseases, and there are 3 important ones we need to know. Goodpasture syndrome, which is a type 2 hypersensitivity reaction where antibodies cause inflammation all along the glomerular basement membrane, leading to a continuous or linear stain on immunofluorescence. One key fact to remember about good pasture is that it's also associated with similar damage to the alveolar basement membrane in the lungs. So, what is the typical presentation for good pasture syndrome? Hematuria and hemoptysis, because damage is occurring in the kidneys and in the lungs. So the patients are coughing up blood and urinating blood. Next is granulomatosis with polyangiitis, also known as Wegener's. And you'll want to look for an autoantibody C-ANCA in these patients to confirm Wegener's. And last, microscopic polyangiitis. Look for an autoantibody to P-ANCA to confirm microscopic polyangiitis in these patients. So these are the three causes that can lead to RPGN. The next type of nephritic syndrome is diffuse proliferative glomerulonephritis, or DPGN. It's caused by SLE, systemic lupus erythematosus, or it can be caused by membranoproliferative glomerulonephritis, MPGN, which, if you recall, is what we studied in the nephrotic syndrome section. So DPGN is the nephritic presentation of MPGN. So MPGN can have both a nephrotic and a nephritic. When it presents as the nephritic, we call it DPGN, diffuse proliferative glomerulonephritis. It's the most common cause of death in SLE. And when people say lupus nephritis, DPGN is usually what they're referring to. Now, classic findings on light microscopy will include wire looping of the capillaries. And you see this here. This is all wire looping. This dark pink hyalinated material, that's the wire looping of the capillaries. And you can see that the capillaries have become narrower. Now, on electron microscopy, there are subendothelial and intramembranous immune complexes and a granular deposition of immune complexes on immunofluorescence. Next is IgA nephropathy, also known as Berger disease. Just as the name suggests, this is caused by a deposition of IgA immune complexes. And they get deposited in the mesangium, leading to mesangial proliferation. So the immune complexes are deposited in the mesangium. On immunofluorescence, we'll see antibodies reacting to IgA immune complexes in the mesangium. Now, clinically, IgA nephropathy usually presents with an infection like an upper respiratory tract infection or acute gastroenteritis. So what's the commonality between a URI and gastroenteritis? Notice that in both of these infections, the infection is occurring where IgA is secreted. It's secreted in the respiratory tract and it's secreted in the gut. So when there is an infection in one of these two places, IgA production increases, and this leads to a flare of IgA nephropathy. Patients will have episodic hematuria with RBC casts, and it's associated with Henoch-Schönlein purpura, which is a more systemic deposition of IgA immune complexes. Last is Alport syndrome, which is due to a mutation in type 4 collagen. Now, is it somatic or sex-linked? The answer is it's sex-linked, specifically X-linked mutation in type 4 collagen. And this mutation leads to a splitting of the glomerular basement membrane. And that has a number of effects because it's not just causing splitting in the glomerular basement membrane, it's causing splitting in basement membranes all over the body. And this leads to deafness due to effects on the nervous system, eye problems, and glomerulonephritis. Now, what other disease that we mentioned during this section also is the result of pathology involving type 4 collagen? The answer is Goodpasture's. Remember, in Goodpasture, we had antibodies binding to type 4 collagen. So that'll help you keep the two straight. Alport syndrome is when there is a mutation in type 4 collagen, and Goodpasture syndrome is when antibodies are binding to type 4 collagen. A 44-year-old woman presents to your office after she sees that her urine is tinged red. You notice that she has a red rash on her cheeks. Will this woman's blood pressure most likely be high, normal, or low? If you said high, you're correct. In this case, the answer comes from knowing the difference between nephritic and nephrotic. Now, the malar rash on the woman's face should tip you off to lupus. And then you will know that the patient's hematuria is probably caused by lupus nephritis. And since the patient has nephritic syndrome, she's going to have hypertension due to salt retention, and that's why the blood pressure will be high.